Hi everyone, thanks for coming to the first OSME lecture of this series. So I'll give everyone a few minutes to join and then we'll get started. Okay, hopefully everyone can hear me. Okay, so I'll wait another minute. Okay, I'll just get started. So today's lecture, we have two topics. So we have to get through hepatobiliary system and also upper GI. So there's quite a lot of content to cover. So I'll do a 5-minute break in the middle and it will be quite fast paced. So it's mostly intended for AKT revision. So focusing on common and like the most high yield conditions. And there is obviously a lot of overlap with lab med content as well, but there will be less of a focus on pathology and the following topics we won't be discussing. Okay, perfect. So I thought I'd start off with a question. So I'll read it out and then you guys can have a think about what you think the answer is. So a 45-year-old woman presents to SCU with a 12-hour history of right upper quadrant pain and fever. She reports experiencing similar bouts for the last 6 months, but says that the pain usually disappears after a few hours. What is the most appropriate next investigation? So I'll give you a few seconds to think about it and then I'll go through it. Okay, so reading the vignette, so she's a 45-year-old woman, so that immediately gives you clues due to the demographic of the patient. She's got this acute history of right upper quadrant pain, so immediately you're thinking, what's in that area? It's the liver and the gallbladder. Fever suggests infection. She's had similar bouts of pain for the last 6 months. That's alluding to biliary colic. And yeah, it comes and goes, but now it's persistent. So, based on this presentation, my initial diagnosis would be acute cholecystitis. So, due to the two symptoms, the right upper quadrant pain and the fever. And the most appropriate next investigation would be abdominal ultrasound. Yeah, abdominal ultrasound because it's minimally invasive. It's very useful in visualizing gallbladder pathologies because you can see the presence of the gallstones and you can also look at the wall thickness, which would give you an indication of whether or not the gallbladder is inflamed. And you can also look at look to see if there is any bile duct dilatation as well. So those would be the signs you'd be looking out for on the ultrasound. Okay, so let's get started on the content. So the first presentation is cholelithiasis. So chole refers to the gallbladder and lithiasis is stones. So that just tells you the location of the stones. So gallstones are present in a lot of people and for most people, they are asymptomatic. However, the problems start to arise as the gallstones dislodge and they move through the biliary tree. So biliary colic is when you have an obstruction of the stones in the cystic duct, but the gallbladder is contracting, and that contractile movement is what's giving you the colicky pain. So with biliary colic, you'd have the right upper quadrant pain that comes and goes, and it's typically after eating and is worse after fatty meals due to the release of cholecystokinin, which then promotes the contraction of the gallbladder. But then it tends to go away, and it can also be associated with nausea and vomiting as well. So if you're examining someone with biliary colic, they would just have the tenderness in the right upper quadrant, wouldn't have a fever, wouldn't have any deranged LFTs if you did a blood let's decline. Okay. And then a key investigation would be abdo ultrasound. So for any kind of gallbladder related pathology, your first, if they ask the next most appropriate investigation, you'd always say abdo ultrasound. And that's what the presence of the stones in the gallbladder would look like. Okay, so moving on to management. Management's quite easy. It's very conservative, lifestyle based. So give them analgesia, also advise for a low-fat diet because that reduces the cholecystokinin and the pain associated with the symptoms. And then you'd want to consider a cholecystectomy, but at some point in the future, and this would just be routine. It's not an emergency. Okay, so the next one is acute cholecystitis, which is what we saw in the question we did at the start. So this is where the gallbladder is acutely inflamed. So it normally occurs when you have a gallstone. The gallstone obstructs the flow of bile, so you get bile stasis. The stasis, as with any kind of stasis in the body, it promotes infection. And with infection, you get a fever. So that explains the kind of constellation of symptoms you'd get. So with the history, right upper quadrant pain plus fever, and that would lead you down the route of cholecystitis. However, in very kind of rare situations, it can occur in the absence of gallstones, and that's known as acalculous cholecystitis, but it's normally very sick patients in ITU. So they'd be febrile, Murphy sign positive. So a reminder, it's where palpation of the right upper quadrant elicits pain upon inspiration. And LFTs are classically normal. There might be some slight derangement, but on the whole, nothing too crazy. You'd have raised white cells and CRP signifying an infection. And as always, abdo ultrasound shows a thickened wall like this. Okay, the management is different to biliary colic. So infection, you'd give IV antibiotics, fluids, analgesia, keep them nil by mouth in preparation for surgery. And current NICE guidelines state that they should have a lap chole within 7 days of admission to get the gallbladder out. Okay, so if you're asked about complications of a cholecystectomy, for example, in an OSCE station, first start off kind of simple. So what are the most common complications associated with any surgery? They'd be infection and bleeding. And then you can start to be a bit more specific. So with any surgery as well, you'd have damage to local structures. So for this one, you'd particularly be worried about the common hepatic duct and the common bile duct as well. And these are two very important structures that should not be damaged. Also, these complications. So post-cholecystectomy syndrome is quite a common complication. It occurs in 1 in 10 people and that have had the surgery, and it is associated with diarrhea, and it occurs due to gallstones either being left in and not properly removed or bile leak, and it can be treated with bile acid sequestrants. And yeah, these are the general complications. Cool. So another question. So a 45-year-old female presents with right upper quadrant pain and scleral icterus. A recent abdominal ultrasound showed stones in her gallbladder. What is the most appropriate next investigation? Okay, so she's got jaundice, signified by the scleral icterus. She's got the pain. But she's not got a fever. And she's already had the ultrasound, so you can't say that. And that showed gallstones. So after that, you've indicated that the stones are present, but you'd want to visualize where exactly those stones are. So because of that, the next most appropriate investigation would be magnetic resonance cholangiopancreatography, or MRCP. Okay, so talking a bit about bowel obstruction. So cholelithiasis is different to cholelithiasis because the gallstones are now obstructing the flow of bile as they're present in the common bile duct. And this means that the patient presents with right upper quadrant pain and jaundice, like in the question. And this jaundice is obstructive. So they would have dark urine, pale stools, and high levels of conjugated bilirubin in the urine and also in the blood. And it might present like biliary colic initially. So yeah, jaundice is the key differentiator, and they'd also not have a fever. In terms of the LFTs, you'd have a raised ALP and GGT because these are the markers that signify hepatocellular obstruction. ALT, AST would be normal because those are hepatocellular damage. And yeah, it would just be these two that would be raised typically. And like I said, a raised conjugated bilirubin as well. So first you do an abdo ultrasound and you follow that by doing an MRCP because that lets you visualize exactly where the stones are in the biliary tree. But yeah, it can be slightly raised as well, the ALT and AST, as the bulb will damage the liver. And this is what the MRCP would look like. Okay, so the management of a biliary obstruction. So as with any surgical presentation, keep them nil by mouth, analgesia, antiemetics, and then the management to get the stones out would be an ERCP. So you can go in through the duodenum and extract the stone, or if they're not fit for that, then you can go in through the skin and do a PTC. And then after you've done all this, then you would admit them and you can then schedule an urgent lap chole. Okay, so this is quite a common exam question. So the key complications of ERCP, and by far the main complication is pancreatitis because you are essentially going in with a tube in very close proximity to the pancreas. So this will result in irritation to the tissue, which can cause inflammation and pancreatitis. And the management for this is supportive, but we'll discuss that in more detail a bit later. Also, less common ones, bowel perforation and biliary tree perforation. Okay, ascending cholangitis is one step above biliary obstruction. So this is where you have infection upstream of the biliary obstruction. So the stasis of bile that we talked about before has now become infected, and this patient is very acutely unwell. So in a question vignette, you'd be looking for Charcot's triad. So that would be right upper quadrant pain, fever, jaundice. Yeah, that would be the components of the triad. And in the elderly, they can also present with confusion and shock. And that would be Raynaud's Pantad. So these are the key features that you'd want to kind of memorize and think about if they come up in an exam question. And this is a useful table of everything we just discussed. Yeah, so that's Charcot's triad. Yeah, and with ascending cholangitis, everything is a bit deranged essentially. So all the LFTs would be deranged. You'd also have markers of infection like elevated white cells and CRP. The patient might be septic, which would make you start the sepsis 6 protocol. They'd have fever, jaundice, and the pain. And as always, abdo ultrasound followed by an MRCP. And in terms of the management, because the patient might be septic, you'd want to take blood cultures and also start IV antibiotics based on the local guidelines. You'd also consider sepsis and treat with septic cyst, like I said, keep them nil by mouth for surgery and the usual analgesia and antiemetics as well. So a lot of the management is the same. So you'd start off with the basic kind of drugs to keep the patient comfortable, fluids to hydrate them. And then based on each individual presentation, there might be different things. So if it's an infection, you'd obviously want to give them antibiotics, and whether or not they'd need to be scheduled for surgery, that would be another thing to consider as well. And if they need surgery, they need to be kept nil by mouth. Okay, and the definitive management, you'd want to ERCP again to clear out all the stones. And the management varies based on the severity of the infection. So if they are septic, then the main kind of priority is making sure they're stable. And then you can do an ERCP after that because you can't just do that in a very, very sick patient. They just deteriorate and die first. Moderate, then you can go in with the ERCP first. And if it's mild, then you'd start by giving them antibiotics for a day or so, and then go in with the ERCP. And as always, you'd want to take the gallbladder out. Okay, so here is another question that we can work through. So we have a 36-year-old woman who's reviewed on the surgical ward, abdo pain and vomiting. She had a procedure to remove a gallstone early that day, so that's an ERCP. Heart rate 109, BP fine. Da, da. Okay, what is the most likely diagnosis? So she's got abdo pain and vomiting and ERCP. So it's pancreatitis. So yeah, the main complication of ERCP that you want to be looking at for, and this is a fairly classical presentation of pancreatitis. And here's another one. We have a 62-year-old man who presents with severe epigastric pain that radiates around to the left. His amylase level is very elevated. What further investigation do you need to request to make the diagnosis of pancreatitis? So, for the diagnosis of pancreatitis, you actually wouldn't need to do any further tests because they've got clinical signs. So they've got the severe epigastric pain, and they also have biochemical markers which are deranged, so very high amylase levels. So because they have these two criteria, you do not need to do any further testing, and you've already made your diagnosis. Okay, so that leads us nicely onto the topic of acute pancreatitis. So this is inflammation, and this leads to the release of pancreatic enzymes. Those pancreatic enzymes then lead to autodigestion of the pancreas. It's very serious, can be life-threatening, and is managed supportively. So this is very common. I feel like it's drilled into you in med school. So what are the three top causes of acute pancreatitis? So it's I get smashed. Classic ones are gallstones, ethanol, and the rest of them. I think important ones would be hypercalcemia and hypertriglyceridemia, also ERCP. So just remember the main ones. Yeah, okay, cool. And the presentation of acute pancreatitis is epigastric or central abdominal pain. They would be very unwell, and they might also present with vomiting. But it's quite a general, generic presentation. So you can't, based on the tummy pain and the vomiting, you can't just say they have pancreatitis. So you need to keep a broad range of differentials in mind. And other differentials for this condition would be sepsis. So sepsis could be from any source, really. For example, if the urinary tract, could also be a ruptured AAA. If they're, and yeah, that's something to be very mindful of if they have tummy pain, if they fit the demographic of typically kind of an older or middle-aged man, or woman even. It could, be in any member of the population. And also bowel perforation, or an intra-abdominal hemorrhage as well. Cool. And with pancreatitis, there are two main signs. So this would be Cullen's sign, and it's the bruising around the umbilicus. And this is Gray Turner's sign, which is bruising around the flanks. A way I was taught to remember this is Cullen C. So it forms a C around the umbilicus. Gray Turner is two words. You have two flanks. So yeah, that's just something I used to remember. Yeah, that's due to the retroperitoneal hemorrhage. Cool. And like I said before, you don't need all three features to diagnose pancreatitis. You only need two. And the most common ones would be the consistent history or exam, and also the biochemical findings of the raised enzymes, so amylase or lipase. And they have to be 3 times the upper limit of normal. So in practice, you are probably not going to do a CT immediately, but you usually do an abdo ultrasound to investigate other causes of the tummy pain and see if there are any gallstones. Okay, so this isn't something you need to know, but it's useful information. And if it comes up in an OSCE, because I feel like pancreatitis is quite high yield, then it's good to mention in the questions because it just helps you stand out. So this is the Glasgow IMRI score, and it's used as a prognostic marker of acute pancreatitis. And these are the various scoring factors that you would consider. But yeah, important takeaways are hypercalcemia is a cause of pancreatitis, but hypocalcemia is a consequence. And it's due to the digestion of the triglycerides and the sequestration of the calcium by the fatty acids. And amylase level is not always a prognostic marker. So yeah, it's not in the scoring system. Cool. What is the most important feature of managing acute pancreatitis? Okay, so the management of acute yeah, the management of acute pancreatitis is fluids and urine output monitoring. So it's mostly just supportive management, making sure the patient is hydrated and they're urinating an appropriate volume per hour. There's no role for antibiotics, steroids, immunosuppression, or surgical drainage. Or surgical drainage as the initial step, actually. But yes, so with fluids, you'd want to monitor the urine output, like I said, aiming for 0.5 mils per kilo per hour. As always, analgesia and antiemetics to make sure that the patient is comfortable. You'd want to encourage oral intake, so they wouldn't really go for surgery. So you'd want to make sure that they're eating okay, and then treat the cause. So if it's caused by the gallstones, then they would need an urgent ERCP, and yeah, and if the Glasgow IMRI score is raised, then you'd want to consider ITU or high dependency unit because this is very serious and it could progress and lead to death. Okay, and in terms of complications of acute pancreatitis, um, it can lead to pancreatic collections around the pancreas, which can form a pseudocyst. It can also lead to necrosis of areas of the pancreas, so the cells die, and this could lead to complications in the future, like diabetes, if the cells producing the insulin in the islets die. And it could also lead to chronic pancreatitis as well, where the structure of the pancreas changes and its overall exocrine and endocrine capacity declines over time. And if it's not resolving, then this is when you'd want to do a CT scan to see if there are any structural problems with the pancreas. And you might see a collection around the pancreas, which might then need to be drained as under interventional radiology. If it's necrotizing as well, you might want to consider drainage, but definitely analgesia. And if it's chronic pancreatitis and they develop diabetes, then want to start insulin therapy and also Creon as the enzyme replacement for all of the pancreatic enzymes which are no longer being produced, which helps the patient to digest their food and absorb it, preventing any kind of malabsorptive deficiencies. Okay, so we have another question. So, a 60-year-old female with a history of alcohol abuse presents to her GP with a 2-month history of pale, foul-smelling stools. When questioned, she says they are difficult to flush. She also describes having lost a lot of weight over the last year. What test is most appropriate in this context? Okay, so if we go through the question, the female has a history of alcohol abuse, which is relevant because it can lead to chronic pancreatitis. And she has a long history of pale, foul smelling stools. So, what that tells me is they're malabsorptive, and she is not absorbing essentially the nutrients from her food properly. They're also difficult to flush, so that suggests that they're fatty, probably steatorrhea. And she's also lost a lot of weight, which kind of confirms the fact that she's not getting adequate nutrition from her diet. And this kind of whole history together suggests pancreatic insufficiency on a background of chronic pancreatitis. So, in terms of making that diagnosis, what test is most appropriate? And that would be a fecal elastase, because that is an indication of the exocrine capacity of the pancreas. Yeah. That leads me nicely onto pancreatic insufficiency. So this can be divided into two groups. So exocrine insufficiency, which is where you have weight loss, steatorrhea, which is what I mentioned, the fatty stools, which kind of float on the toilet and are difficult to flush. And you can also have endocrine insufficiency. So this would be your diabetes. The pancreas is responsible for the production of insulin. And if you don't have that, then you'll have the classic symptoms of diabetes. So thin, thirst, toilet, all of those. And if it's acute and it's not picked up, it could even present initially as DKA. So the patient would be, very unwell. They'd have abdo pain, vomiting, might even have decreased consciousness. Yeah, so that's definitely something to be mindful of if you suspect endocrine insufficiency of the pancreas. And the management, like I said, is Creon, which is just enzyme supplementation. It's also taken by patients with cystic fibrosis who also have pancreatic insufficiency due to the mucus, and insulin for the diabetes. Yeah, and some of the causes is what we talked about before. So the chronic pancreatitis, the necrotizing pancreatitis, where the parts of the pancreas die, and also cystic fibrosis. But that tends to be picked up a lot earlier in the newborn screening. Okay, another question. So a 70-year-old male notices that his skin has become more yellow over the last few days. He reports no pain, but says he has been more tired than usual for the last few months. Given the most likely diagnosis, what investigation should be requested? So starting off with the demographic of the patient. So they are a 70-year-old male, so quite old, which increases your risk of various pathologies like cancers. Skin has become more yellow, so jaundice. No pain, so it's a painless jaundice, but they have been feeling more tired. So you would want to do a CT scan. So based on this presentation, this kind of indicates to me that they have an obstruction to the flow of bile. So that's why they have the jaundice. They have no pain, but they have also been becoming more tired over the last few months. That's a very long history. So, based on that, I would suspect pancreatic cancer. And pancreatic cancer has a very kind of insidious onset. So, it's diagnosed very late, and due to that, its prognosis is very, very poor. So, it only really causes symptoms like the jaundice when it's causing an obstruction, and it has to grow to a certain size to cause that obstruction. So yeah, in terms of visualizing it, you'd want to order a CT because that lets you see the abdomen and the pancreas and any masses. These other investigations would not be as sensitive at picking that up, which is why you would start off with a CT scan. Okay, so pancreatic tumors can present as painless jaundice, like I said, and that is signified by, I can't say it, Courvoisier, I think, Courvoisier's rule, which states that painless jaundice, in the absence and gallbladder or like right upper quadrant swelling, suggests pancreatic cancer as opposed to other kind of gallbladder related pathologies like gallstones, because pain would really have to be present for them to kind of for it to point you in the direction of biliary colic, cholecystitis, etc., etc. And yeah, patients can also have central abdominal pain, which mimics chronic pancreatitis as well. Um, but it's more of a kind of long-standing history. They might also have other symptoms you want to ask about in the history. So your classic red flags of cancer, so loss of appetite, fever, weight loss, night sweats, tiredness, etc. And the classic go-to investigation would be a CT scan. So yeah, like I said before, they mostly just present late, which is very sad after significant mets. So they can metastasize to the liver via the portal system, and they tend to be, yeah, very poor prognosis. And the management of pancreatic cancer would be a Whipple's to remove the tumor and also reroute basically the digestive tract. Um, yeah, very complicated, very long procedure. I think this is our last question for this PowerPoint before we do upper GI. So, yeah, a 35-year-old female presents with a 3-day history of right upper quadrant pain, fever, and malaise. Today, she has also noticed that her eyes have turned yellow. She has recently returned from visiting family in South Africa 3 weeks ago. What test is most likely going to reveal the diagnosis? Okay, so 35-year-old female, so quite young, presents with a 3-day history, so acute, very short history. Right upper quadrant pain. So right upper quadrant pain, we're thinking gallbladder or liver, fever, infection, and malaise. Her eyes have turned yellow, so she's got scleral icterus. That tells me that she's jaundiced. She's recently returned from visiting family in South Africa. So that's a travel history, and you'd want to think of any potential pathogens that are endemic to South Africa 3 weeks ago. So she's returned quite a significant time before she presents with this. So it suggests something that has quite a long-ish incubation period. So what test would we want to do to reveal the diagnosis? So based on the jaundice, the right upper quadrant pain, I'm thinking a hepatitis. And based on the very, acute presentation, a 3-day history, she's quite unwell, she's got a fever, um, and malaise. I'm going to be thinking along the routes of hepatitis A because that's one of the acute forms of hepatitis, along with hepatitis E as well. And hepatitis B and C are more of the chronic forms of hepatitis, and they wouldn't present with such kind of sudden acute symptoms. They'd present like over a longer period of time. So that's why it's Hep A and not Hep C. So AMAs, you'd be doing AMAs in someone that you'd suspect has PBC, and this history just doesn't match that. Abdominal ultrasound. So while I said before that you do an abdominal ultrasound in anyone with right quadrant pain, you aren't really suspecting gallstones in this scenario because of the travel history. And yeah, you'd be suspecting hepatitis and you'd want to do serology. However, it doesn't mean you wouldn't do an abdo ultrasound. It's just this is the most likely to reveal the diagnosis, which is what the question's asking for. And a stool culture, just probably not. Yeah. So in terms of ascending cholangitis and its mimics, it's really important to remember that there are medical presentations which can mimic common surgical problems because you probably see a phrase or a presentation, you immediately think, oh, it's ascending cholangitis. But it's important to keep your mind open so you don't immediately jump down that pathway and, get biased because there might be some other kind of small clue in the question that is trying to lead you down another route. So it's important to keep your diagnostic options open until you kind of confirm that that's the right diagnosis. So in terms of mimics of ascending cholangitis, like we did in the question, acute hepatitis can mimic that, so Hep A or Hep B. Also, alcohol-induced hepatitis as well, or autoimmune hepatitis, because these all present in quite a short time frame, and that makes them better mimics than hepatitis. I think this should be E, not B. Oh, sorry. Yeah. And other things that could mimic it are hepatic abscesses, also PBC or PSC. So we went through this quite a bit during LabMed. So they have different kind of demographics. So this tends to be in more in women, and this tends to be more in younger men and is associated with ulcerative colitis as well. This tends to present with kind of itching and symptoms like that. And yeah, it's quite high yield, so I would recommend revising these two quite well. And they also have different serological markers that you want to look out for, like the anti-mitochondrial antibodies for the PBC. Cool. So that brings me to the end of this half of the presentation. So I think we'll take maybe a few minutes for a break before we start the next one, because the next one is a bit longer and it's upper GI. So yeah, like stretch your legs, go get some water, and then I guess we'll start around like 6:40. Cool. Okay. So I think I'll get started on the second half of the lecture. So for this, we'll be covering upper GI. And as always, the main aims of this are the AKT. So going to start off with some important definitions. So these words get mixed up quite a lot. And I remember I was quite confused between dysphagia and what dyspepsia actually was, because I feel like they use it for everything. So dysphagia is difficulty swallowing, and that's quite a specific definition. Odinophagia is pain while swallowing, also quite specific, whereas dyspepsia is quite a broad definition, and it's used to describe a complex of upper GI symptoms, and they are normally present for 4 or more weeks, making them quite chronic. And it's a combination or and kind of the individual presences of upper abdominal pain or discomfort, heartburn, acid reflux, nausea, or vomiting. So it's quite a broad definition, and you guys aren't expected to kind of remember like or list off each kind of individual aspect of it, but it's important to be aware of what kind of presenting features might fall under the umbrella of dyspepsia, because all the NICE guidelines use the term, not all of them, but some of the NICE guidelines use the term dyspepsia, and they use dysphagia as well. So these ones are very important to kind of be clear on and understand the distinction between them. Okay, so indigestion is a term which is used to refer to abdominal pain after eating. And the main differentials you'd want to consider when thinking about indigestion would be gastritis, peptic ulcers, malignancies like stomach cancer, and also kind of less common ones like functional dyspepsia or even gallstones. Some people might refer to the pain they have from gallstones as indigestion when it's quite distinct. So gastritis is essentially just inflammation of the stomach lining, as you can see here, and it's very common in the population. So key symptoms are epigastric pain, which is typically exacerbated by eating. Also nausea and vomiting, or if it's very severe gastritis, you might even see patients who are vomiting blood, which is hematemesis, or they have kind of black foul-smelling stools, which is melena, and it's due to the digested blood from an upper GI bleed. So when you're thinking about the stomach and factors that cause gastritis, peptic ulcers, etc., this is quite a useful concept to understand, as it helps you kind of conceptualize the management, and it just means you're not memorizing a bunch of stuff blindly. So the gastric defenses include mucus secreting cells, which protect the mucosa, and immune cells as well. And factors that cause gastric damage oppose this, and this includes stomach acid, which might be overproduced in certain people, H. pylori, alcohol, smoking, caffeine, the usual offenders, and also NSAIDs. So these are important lifestyle factors you'd want to consider asking about in a history from someone that presents with kind of epigastric pain that's worsened by eating. And NSAIDs are especially bad for the stomach because they inhibit the production of the gastric mucus, and the that is why the prescription of NSAIDs, you have to prescribe omeprazole or lansoprazole or some kind of PPI alongside the NSAID, as this reduces the secretion of the stomach acid and helps kind of balance the damage to the gastric mucosa with reduced stomach acid, which should be a protective factor. Okay, so some cases of gastritis can be linked to a trigger. And like I said before, NSAIDs are a main one. So if a patient is taking NSAIDs, you might want to recommend cutting down on the number of tablets they take, or making sure that they take them after they've had a full meal, or prescribing a PPI with it. Also, repeated steroid use is not good for the stomach. But most cases are kind of combinations of all the things we just discussed. And it's important to take quite a holistic approach to a patient with gastritis. However, if it's refractory to kind of these lifestyle approaches, it might be caused by something a bit less common. So autoimmune gastritis might be a differential you'd be considering if, yeah, it's not responding to lifestyle management or even medical management. Okay, so treatment. So initially, you'd want to advise them to, yeah, just basically cut down on the NSAIDs, stop smoking, reduce the alcohol intake. Also, ask them if they've tried over-the-counter antacids, which might be useful in reducing the overall acidity of the stomach. However, if these methods are unsuccessful, you would want to consider testing them for Helicobacter pylori and then subsequently treating it if it's positive. Also, common medications that you should know about, PPIs, which inhibit the proton pump, which secretes the stomach acid. Also, H2 blockers, which are antihistamines, like ranitidine, which reduce the acidity of the stomach as well. So, in terms of H. pylori, the main tests that are done to look for it are the urea breath test and the stool PCR test. And these typically done in GP settings. So before you do a test, you need to have a 2-week washout period in which you don't take PPIs for 2 weeks before testing, because if you do, then this increases your chance of a false negative result. And the management of H. pylori in order to get rid of it would be a triple therapy. So that is a combination of high dose PPI along with 2 antibiotics. And that varies based on the region you're in. But in Oxford, you would take lansoprazole, amoxicillin, and clarithromycin. And strict adherence to this regimen is really important for clearing the infection. In some cases, you might have treatment-resistant Helicobacter, in which case you would have to take, I think it's 4 drugs, and one of them is bismuth, which is less, it's not very pleasant to take. But yeah, it's very important that after you take the antibiotics as well, you do a test of clearance. So you test for Helicobacter again to make sure that it's not one of the resistant strains. Okay, so moving on to our next differential, which is peptic ulcer. So these exist kind of on a spectrum. So a peptic ulcer is essentially just a breakdown of the epithelial lining, and you can have gastric ulcers and you can also have duodenal ulcers. So the key symptom is the epigastric pain, but they do vary slightly in terms of exam question vignettes if they're trying to lead you down the route of gastric ulcers or duodenal ulcers. So gastric ulcers, they normally say the discomfort is made worse after you have a meal. And with duodenal ulcers, they say that the discomfort is actually made better after you eat. However, this is not necessarily true, and there isn't very good evidence for this, but it's just an exam kind of classic. And peptic ulcers can present as an upper GI emergency. So if you have a bleeding peptic ulcer, then you might have hematemesis, where you're vomiting up large quantities of blood. And if a patient, presents with that, then you'd want to take an A to E approach, because that is an emergency. They're losing a lot of blood. You'd want to prioritize stabilizing them, making sure they don't go into hemorrhagic stroke, sorry, not strokes, shock. And also they might have melena, which is what we talked about before. It's where the digested blood is present in your stool. Okay, so peptic ulcers can have a variety of complication. So the kind of main one that is commonly talked about is bleeding. So if you have a heavy bleed and you lose a lot of blood, you can then have iron deficiency anemia. And this is something that is important to investigate. So if you're in the GP and a patient presents with iron deficiency anemia and you can't kind of figure out what the cause is, it's really important to make sure that they're not losing blood from their digestive tract, either upper GI or lower GI. And yeah, it can also be a major hemorrhage as well, which is a medical emergency. It can also perforate, which can lead to peritonitis, very serious, and also form a stricture, which can lead to kind of shrinkage and scarring. over time as well. So in terms of the etiology, it's basically the same as gastritis. So this is quite a common trend with the kind of pathologies we'll discuss in this lecture. The main risk factors stay the same, which is quite good for your exams because you just have to learn the common list and it applies to most of these cases. So the risk factors for peptic ulcers are just NSAID, steroids, smoking, alcohol, H. pylori, etc. And these all kind of exacerbate the inflammation and irritate the stomach lining. So same treatment. And here is a question. So in a 2-week wait referral for dysphagia, what is the first investigation that will be performed? So the main definitive investigation that would give you a diagnosis would be an OGD. So putting a endoscopy tube into the mouth, which can then visualize the esophagus, the stomach, and the duodenum, as this will help you visualize and see if there's any tumors, any changes to the stomach lining, any ulcers, etc. So yeah. This is the definitive diagnosis, endoscopy, and these are kind of findings you might see upon doing that. So this is gastritis, that is an ulcer, so you can see the denuded kind of area in the mucosa, and this is an adenoma, which you can see here. But we can't scope everyone with indigestion, so it's really important that we have kind of clear-cut criteria to determine who we actually put a scope in. So to kind of get you thinking about that, here is a question. So in this case, we have a 59-year-old man who has a history of recurrent heartburn, and he presents to his GP reporting that he started to get a sensation of food getting stuck in his chest. It doesn't bother him that much as he's just started to choose softer foods. What is the most appropriate management plan? So with this case, it's a bit tricky because some people might just say, tell him to stick to soft foods, take a kind of wait and watch approach. So kind of see if it gets better, and if it doesn't come back, good safety netting. But that wouldn't be appropriate in this scenario due to 2 factors. So the age of the patient, they're a 59-year-old man, and also the symptom of dysphagia, so that he feels like the food is getting stuck in his chest. He is having difficulty swallowing. And these are 2 big red flags. So we'd want to do a 2-week wait referral because we suspect cancer. So the NICE criteria for endoscopy are quite clear, and it's really important that you learn this for your AKT. So you have to ask yourself 2 questions. So number 1, what age are they? Yep. And do they have any alarming symptoms? So you offer a diagnostic endoscopy in anyone who is aged over 55 years old and they have an alarm symptom, or if they have dysphagia. So so these are the alarm symptoms, and these are the kind of red flags that you want to ask about in a history. And these would make you very kind of highly considering upper GI cancer. So A is anemia, L is weight loss, A is anorexia, R recent onset and getting worse, and M is the kind of signs of upper GI bleeds. So if they have any of these symptoms and they're over 55, immediately send them off for a diagnostic endoscopy. So yeah, next we'll be talking about malignancies. So the main risk factors for malignancies are the 2 kind of conditions we talked about, so gastritis and peptic ulcers, which is why I said they exist kind of on a spectrum of severity, and one can progress into the next. And also a high salt diet. There are higher incidences of gastric cancers in certain countries and cultures that have a naturally just the diet that's higher in salt. And it's also more common in obese individuals. So that is a risk factor that you would look out for in a question stem. Okay, so the kind of main symptoms of gastric cancer would be early satiety, so feeling full after a meal earlier than you normally would, epigastric pain, and yeah, either anemia or the bleeding. And the treatment would be a gastrectomy, either a complete one or a partial one to just get rid of the section that has a tumor or the whole stomach, and in combination with chemo and radiotherapy. And this is quite small print, I would say. I don't think I've ever seen a question on functional dyspepsia, but it could come up. So it might be a good idea to kind of read through this. I'll just summarize it quickly. It's basically just having symptoms of dyspepsia, but the endoscopy findings are completely normal. And there are two main kind of categories of this. So epigastric pain syndrome and postprandial distress, but they normally are just called functional dyspepsia. Management is exactly the same as what we just talked about, reducing those risk factors, getting rid of H. pylori. Also, something to consider is stress and anxiety do play a role in gastritis and peptic ulcers and dyspepsia. So that might be another thing you'd want to ask in a history or discuss with your patient, because yeah, I think they can have quite profound effects on your stomach. And also considering other causes, so keeping your range of differentials quite broad. Oh, just had the answer. Okay, well, guess you won't have to figure it out. So let's just go through it. So a 26-year-old woman presents to her GP with a 4-week history of mild epigastric discomfort following eating. She has not lost weight and denies melena. She smokes 20 cigarettes a day. What is the most appropriate initial management plan? So this kind of contrasts with the previous question we looked at, where the man presented with just one symptom, but it was a big red flag symptom. So this woman is 26, so quite young, and she has a 4-week history. So like we said, the criteria that the initial definition discusses, the symptoms have to be present for 4 weeks or longer. And she has the epigastric discomfort, but she doesn't have any of the red flag alarm symptoms. So no weight loss, no signs of upper GI bleeds. She is a smoker, which is a big risk factor for gastritis, peptic ulcers, etc. So you wouldn't need to send her for an urgent endoscopy, and instead you would stick to kind of conservative lifestyle management. So you would encourage her to quit smoking, also change her diet to reduce salty, spicy foods, and also recommend antacids, which can be bought over the counter. And she can take them after a meal to reduce the symptoms. So with these kind of presentations, it's really important that you remember the NICE guidelines and you're able to kind of confidently say whether someone needs an urgent endoscopy or whether you're happy managing them conservatively. So yeah, it's quite high yield in AKT, I would say. So the next presentation we're looking at is heartburn. So heartburn is essentially burning pain in the chest, which is made worse by lying down. And the main differentials for this, as opposed to the one we looked at before, would be GORD, esophagitis, and malignancies. So these are all kind of esophageal pathologies as opposed to gastric pathologies, like the indigestion. So starting off with GORD, this is also very, very common and it's present in a large proportion of the population. So the causes, there's a wide range of causes and there is also a lot of overlap, and that's just a recurring pattern that you'll see with this lecture. A lot of the stuff is, they're very common presentations and they have very kind of overlapping risk factors, which makes it quite easy to learn. So GORD is caused by relaxation of the lower esophageal sphincter, which you can see here, which causes the acid in the stomach to rise back up through the esophagus. And that gives you that feeling of heartburn and the kind of pain in your chest. Also burping, kind of like you can also have acid rash and the kind of taste of acid in your throat and various other kind of symptoms. And it's made worse by these lifestyle factors. An important one is position. So if someone has a meal and then lies down, that encourages the flow of the kind of undigested food and the acid back up into their esophagus, and that can make their reflux worse. Also, various drugs. So you'd be thinking about tricyclic antidepressants and anticholinergics, which can promote the relaxation of the lower esophageal sphincter, and also pregnancy as well, which is another main cause of GORD. Something else to think about would be a hiatus hernia. So this is where there is a defect in the diaphragm, which leads to the part of the stomach coming back up through the diaphragm and kind of, yeah, as you can see in this picture here. And this would also lead to reflux, but it's quite common in babies, and that's, yeah, something else to look out for. So I kind of mentioned the typical symptoms of GORD. So you have heartburn, the taste of acid at the back of your throat, burping. Other symptoms can be sore throat, pain on swallowing, also regurgitation, which is where you bring the food back into your mouth. And this is undigested food, so it is different to vomiting, and also a nighttime cough. So I think the nighttime cough one is quite popular in question like vignettes. And it's really important to clarify what the patient means by reflux as well, because it means different things to different people. And like we said before, with dyspepsia, it has such a kind of broad, it's such a broad definition. It can mean so many different things. And yeah, just ask the patient what symptoms they're experiencing, as that can help you make a better diagnosis. Okay, Barrett's esophagus is a lab med favorite. So this is where you have metaplasia of the lower third of the esophagus, and it's due to chronic damage to the lower part of the esophagus by the stomach acid. So it's essentially a protective mechanism. So the stratified squamous epithelium is progressively over time replaced by simple columnar cells, and it's caused by repeated irritation. And it's quite serious because it is one of the main risk factors for developing an esophageal adenocarcinoma. So yeah, as you can see here, this is the sphincter, this is the relaxation. You can see the acid kind of rising back up. That leads to chronic irritation, gets worse over time. And it's really important that we identify this and treat this, because we want to reduce the patient's symptoms, which might be reducing their quality of life, and also the risk of developing a cancer. So yeah, all of these measures that we have talked about. And it's the same. So yeah, I think this could come up quite easily in an OSCE as like a counselling station. So it's a good idea to kind of categorize these in your mind and present it to the patient in these kind of distinct groups. So it makes it easier for them to kind of digest and understand. So first starting off with lifestyle, and then kind of discussing the kind of more medical management and also H. pylori aspect of it. And yeah, if the Barrett's esophagus is confirmed and is persisting despite trying all of these measures, you might need to try surgery. So this is called a Nissen fundoplication, and it's where you stitch the sphincter to make it smaller to reduce the kind of backflow of acid. Okay, and the next pathology we'll be looking at is esophagitis. I'm going to have some water. So esophagitis is where the esophagus becomes inflamed. So as with anything, itis means inflammation, and it has a broad range of causes. So it can be caused by reflux, but it can also be infective. So in terms of things that might point you down an infective route, a big one would be Candida. So candidiasis is more common in patients who are immunocompromised, and that occurs with candidiasis like anywhere. So in the mouth, in like vaginal thrush, anything. So yeah, it's more common in immunocompromised people. And also a recent virus is also another risk factor for infective esophagitis. Another cause is eosinophilic, but that is rarer. Symptoms, very similar that we've talked about. Management, so it is slightly different based on the cause. So reflux is the same, so PPI and the risk factors. Infective, you'd want to treat the underlying cause of the infection. So if it is Candida, then you'd give them an oral antifungal. And if it's viral, normally conservative. If it's persisting, or if you know the specific virus causing it, then you can give them acyclovir if it's a herpes virus. And eosinophilic, you can also try steroids as well. Okay, esophageal cancer. I think you guys get kind of specific teaching on esophageal cancer. So you should already know a bit about it. So these are the main presenting symptoms. So if they have dysphagia, that's a big red flag. If they also have melena or hematemesis, and also like the feeling of something in their throat as well, that's another big red flag, or pain when they swallow. And these in combination with the cardinal symptoms of cancer, so your weight loss, anorexia, also anemia, and if they have any palpable nodes, particularly like the supraclavicular nodes that you feel for in an abdo exam. So that's a common site of metastasis of any kind of upper GI cancer. So stomach cancer, esophageal cancer, and that's Burkhardt node. So you would do an endoscopy in anyone if they have dysphagia, because that's like the main red flag. And you would also refer them for endoscopy if they are older than 55 years old and they have the alarm symptoms that we talked about previously. And here is another reminder. Okay, so another question. A 50-year-old man is diagnosed with grade 3 esophageal squamous cell carcinoma midway down his esophagus. His CT scan shows no evidence of lymphatic spread or mets. He is otherwise healthy and walks 2 miles a day. His case will be referred to the MDT, but what is the most likely suggested management plan? So with this, you are going to be considering various factors. So he has a quite high grade cancer, so that means that it's very locally invasive, and it's a squamous cell carcinoma. So yeah, just remember the differentiation. So with the lower third of the esophagus, you'd be thinking about adenocarcinoma because it's glandular. Upper part, you'd be thinking of squamous cell. That's just a random tangent. And his CT does not show any spread, which is good. He is healthy and well. So the most likely management plan would be a radical esophagectomy. So surgery is really important for esophageal cancers. So removing the tumor because they are very aggressive. A stent would definitely not be enough. You need to cut out the tumor. Resecting the tumor with endoscopy is also not enough because it's very high grade tumor. So you'd want to make sure that you are taking out the whole esophagus to prevent recurrence. Chemo and radiotherapy alone would not be enough because it would compress his airway if it continues to grow, and you would essentially want to remove it and then supplement that with chemo and radiotherapy if needed. So if they are palliative and if there's evidence of spread to other parts of the body, then you would put a stent in, as that can minimize the symptoms and help them to continue to drink and maybe eat soft foods. And a radical approach would have to be taken to esophageal cancer, so esophagectomy or radical chemoradiotherapy as well. And because of the location of the tumor and the narrowing of the lumen of the esophagus, it does require permanent soft foods because you can't get solid food past this obstruction. Okay, so this is just a reminder of the definition of dyspepsia. And why does NICE focus on dyspepsia? why can't it just use a different word that's easier to understand? And it's because many of these conditions coexist, and they all have the same kind of risk factors as we saw, and kind of link on from each other, and they're all very intertwined, essentially, is what I'm trying to say. And the management is also the same, and the investigations are also very similar. So that's why it's just to simplify things in primary care. So yeah, here is a useful flowchart in terms of the management of dyspepsia. So just to review this quickly, because it's a really important concept, um, if they have these red flags, you immediately send them for endoscopy. If they don't, then it's a lifestyle modifications. If they don't work, you test them for H. pylori. If it's positive, eradicate it. And then you can go down that pathway. If it's negative, then you treat them medically with PPIs or antihistamines. Sorry, H2 blockers. I feel like that could lead to some confusion. And yeah, that's essentially the whole pathway summarized. And if you learn that for your exams, you'll be in a good position. Cool. Yeah. So we have already covered structural differentials for dysphagia. And the main ones you should be thinking about are malignancies, but there are a variety of other kind of functional causes, or problems with the lumen of the esophagus that you also have to know about. So one is esophageal stricture, and that is a narrowing of the esophagus. It's benign, so not cancerous, but it can occur secondary to reflux disease that has been left untreated. And over time, it leads to erosion, and the formation of these kind of narrow bits of scar tissue or strictures. And it can also occur secondary to esophagitis, which happens recurrently as well. So strictures can be managed conservatively by changing your diet, so perhaps including softer foods. But you can also dilate the stricture endoscopically if the patient is experiencing significant symptoms, or they're not able to eat or drink as well as they would like to, essentially. Oh, I don't know why it's putting all the answers on. That's annoying. Okay. So a 76-year-old man presents to his GP with a 2-month history of feeling like food is getting stuck when he swallows. He also says that he can sometimes feel a lump in his throat when this happens, which is sometimes accompanied by bad breath. What is the most likely diagnosis? So unfortunately, the answer on the screen is a pharyngeal pouch. But I feel like questions on this are always quite similar. So they always have a mention of like feeling like food is getting stuck when you swallow, so dysphagia, and also feeling like a lump. So if you examine them, you will also be able to feel like a lump in their throat. And there is this classic giveaway of being accompanied by bad breath. And that's because the food kind of collects in that pouch, and that leads like the bacteria breaking it down and producing like the odor associated with the bad breath. So yeah, if they have a combination of these symptoms, then that leads you down the route of pharyngeal pouch as opposed to a cancer or a stricture. Okay, so yeah, like I said before, pharyngeal pouches present with halitosis, which is bad smelling breath, and also regurgitation, because the food is undigested and is going back into the throat. And you might also be able to see a lump, which appears after they eat as well. So it normally happens in elderly patients. So, like in the question we just did, the patient was in their 70s, but we don't know why it happens. It's just quite a common thing that you should be aware of. And the treatment is conservative, but it can also be managed surgically. So yeah, with all of these kind of upper GI pathologies we've talked about, most of them do have a conservative treatment option. So it's important to mention that to the patient, and before also giving them the option of having it repaired surgically if it's affecting their quality of life. Yeah, and another diagnostic method you could use in addition to endoscopy would be a barium swallow, as that helps you visualize the esophagus, and you can also quite clearly see the outpouching. So yeah, you can see that quite nicely here. But with these patients, it is a good idea to do an endoscopy before you make this diagnosis instead of just making it clinically, because you'd want to rule out any more kind of sinister pathologies like cancer. Um, yeah. Okay, so this is another question, and the answer isn't on the screen, which is good. So, an 81-year-old female presents to her GP with a 2-month history of feeling like food sometimes gets stuck when she swallows. She has always been a slow eater, but now spends even longer as she has to wait for it to go down. She denies any weight loss. What investigation is most likely to give the diagnosis? Okay, so I think this one is a bit trickier. So she's got a quite a long history of dysphagia, and she is taking quite a long time to eat her meals, but she doesn't have any of the kind of red flag cancer symptoms, so no weight loss, anything like that. And she's quite old, so she's 81 years old as well. So, taking all these factors into consideration, you would be suspecting an achalasia. So, you'd want to do an esophageal manometry. So, I do think this question's quite hard, but I'll be explaining what achalasia is on the next slide. So, achalasia is a disorder of esophageal motility. So, it's when the esophagus loses its synchronicity. So, when you swallow food, the parts of the esophagus contract in succession to kind of move the food down to the stomach, which is peristalsis. And in achalasia, your peristalsis is basically less effective than it should be. And unfortunately, the lower esophageal sphincter also doesn't relax. So you have this tight, constricted lower esophageal sphincter, and the part above it has dilated. So you have this functional kind of disorder of the esophagus, which means that it's a lot more difficult for you to swallow food. And that's why you have the dysphagia. And it has this kind of characteristic appearance on a barium swallow as well, like a very kind of broad, wide esophagus and a very teeny sphincter. So it can be, lifelong, but it can also be slowly progressive and presenting later in life, like in the 81-year-old lady in the question. And the classic symptoms are slow eating because you feel like the food is getting stuck in your throat and you have to wait for it to pass before you can take another bite. And the main investigation that you do here is esophageal manometry, which is shown here. And the management, as always, we have a conservative option, which is eating slowly. And medical option is Botox, so injecting the botulinum toxin to relax the muscles of the lower esophageal sphincter, which can kind of facilitate the passage of food into the stomach, which can be, very useful in terms of relieving the symptoms, but it is temporary, so it only lasts for 3 months. And for some patients, they might want surgical management. So that would be a laparoscopic cardiomyotomy, which is where you go in and cut the lower esophageal sphincter to make it wider. And yeah, that is a permanent solution. But of course, you have to consider factors like, is the patient fit for surgery? Would they be able to tolerate the anesthesia? All of these factors when, going down the surgical route. Okay, and I think the last kind of broad topic is hematemesis and melena. So there are a kind of wide range of differentials if someone, for example, in an OSCE is vomiting blood or they have the black tarry foul smelling stools, and these are what you'd be thinking about. So starting off with the mouth and the nose, they might have a big nosebleed and they might have just swallowed a lot of blood, which is being vomited out or digested and going in the stools. They might also have post-tonsillectomy bleeding. So post-tonsillectomy bleeding is quite serious. So if it's very acute within 24 hours, you'd want to send them back into theatre. And if it's a week later, you'd want to send them to hospital for antibiotics. because that suggests that there's an infection. And yeah, it can also be due to an esophageal pathology, so a Mallory-Weiss tear, esophageal varices. So with esophageal varices, you'd typically be considering someone with a history of alcohol abuse, because that increases the portal hypertension, all that sequence that leads to the esophageal varices. Also, Barrett's esophagus, esophagitis, also esophageal cancer, any of the things we talked about that can cause an upper GI bleed, stomach, gastric ulcer, gastric cancer, and in the duodenum, a duodenal ulcer. So I think this is quite a nice way of thinking about the differentials if you're asked about it. So starting off with the mouth and the nose and ending up at the duodenum. And if in doubt, you can just say like an ulcer. So you can have a gastric ulcer, duodenal ulcer, or you can say cancer because you can have cancer of the esophagus or the stomach. So yeah, if you get stuck, there are quite easy kind of crutches you can use before you think of the other slightly more niche pathologies. Okay, so this is a question. So a 34-year-old man presents to the ED after vomiting red blood. He has a smoking history of 10 cigarettes a day for 15 years. He vomited 4 times this afternoon. The most recent time showed bright red blood. What is the most likely diagnosis? Okay, so 34-year-old man, quite young, vomiting red blood. So immediately thinking hematemesis and kind of going down the differentials of where the bleed might be. They have a smoking history for quite a long time. They've vomited a lot this afternoon. And this makes me think the most likely diagnosis is a Mallory-Weiss tear. And that's because they have an acute history of vomiting quite a lot, and that increase in the pressure in the esophagus can lead to a tear, and that tear is known as a Mallory-Weiss tear. So yeah, it's basically a tear in the esophageal mucosa due to repeated retching or violent coughing, and it typically does self-resolve, but it's really important to be mindful of that, as kind of keeping that in the back of your mind if you see a question where someone has been vomiting and they end up vomiting a lot of blood. Because I think I've definitely seen this in quite a few exam questions. So yeah, it's a good thing to remember. I don't think the slides mention Boerhaave. I'm not sure if they do. Okay. So in terms of differentiating between a Mallory-Weiss tear and Boerhaave syndrome, so that is a lot more severe, and the patient typically presents in shock. So they would be a lot more unwell, and they might be hypertensive, tachycardic, etc., high respirate, all those kind of features of shock that you'd classically see. And yeah, that's where there is like a tear in the esophagus, and that can lead to like peritonitis, and it's very, very serious, and they need to be admitted immediately and treated. Okay, so the next one is esophageal varices. So this is where you have dilatation of the esophageal veins due to portal hypertension. And you would be suspecting varices if they have a history of liver cirrhosis and yeah, chronic liver disease. So if they've consumed large amounts of alcohol throughout their life, or if they have signs. So if you do an abdo exam and they have signs of liver disease, so put medusae, other kind of features like on the chest, organic matter, etc. And esophageal varices are very serious, and they have a high risk of death if they rupture. And patients would need an urgent endoscopy in this case, and they can also be treated using like band ligation and various other methods. So yeah, in general, if someone comes to you and they are having an upper GI bleed, you would want to take an A2E approach. So resuscitate the patient. If it's a severe bleed and they're anemic, if you do VBG, then you'd give them blood. And you'd definitely want to refer them to gastro, and consider an urgent endoscopy as well. So this would allow you to identify the cause. As we saw, there's such a wide range of causes, and it's really hard to be sure without actually putting a tube in and visualizing it. And the endoscopy also lets you treat it. So yeah, these are various methods of treating if they, for example, have a bleeding varus. You can do band ligation, also gluing, cauterization if there's like a point source of the bleed, etc. And yeah, that is the end of the talk. Hopefully it didn't take too long. Sorry, I had a lot of content to get through. It would be really helpful if you guys filled in the feedback form, because that will help me improve for my next, I think it's next week's lecture. And yeah, any suggestions. And also you'll get the slides emailed to you if you fill in the feedback form. So yeah, that's all from me. Um, yeah, I think hopefully you guys have scanned that, I think, so I can stop sharing. Yeah, okay. So I hope that was useful. And yeah, I'll see you guys for I think, the one after the next one. Okay. Yeah, it's one feedback link for both the PowerPoints. Yeah, any feedback would be really appreciated. Thank you.